to say you're okay for recording.
That's brilliant, so thank you. And some of us very much do quite a lot of work with Wessex Cancer Alliance, the Primary Care and ICB and NHS England too, all very much supporting each other. So a little bit of housekeeping. So as it's already become apparent, Jackie is our navigator for this meeting. Give us a wave, Jackie. I think everybody's seen you already, so that's wonderful. So as I've just said, we do wish to record this meeting to support note taking, but also, as long as our speakers are comfortable, it would be wonderful if we could upload this to our YouTube and then pop it on our website for everybody to view at their leisure. And that'll be available about 14 days time. We'll be sending the link out as well. So please do introduce yourselves in the chat box and share your contact details if you wish to receive the notes and information from this meeting. And we can always add, if you would like, you to our contact lists. Also, if you wish to receive our monthly useful updates. Jackie will mute all our microphones, even keep me quiet in a moment as well, to help manage the distraction of outside noise. You may wish to turn off your camera too, because that helps with connectivity. There will be an opportunity for questions to be asked at the end of each session. So we would ask you to pop your questions into the chat box and I will then present them to the speakers. It just seems to work and flow better because we've done quite a few of these meetings now. And then if needed, I'll refer those on to the speaker. We have lots of questions. What we tend to do is we put any unanswered questions into a question and answer format, and then we email that to our speakers for them to reply, and then we send that to all our attendees. We are not, I know I've already said that we work in partnership with Hampshire Hospitals, but we aren't able to answer any specific questions about current or future Hampshire Hospital services. But if you do have a specific question, then please put it in the chat box and we will forward that to the appropriate person. And remember, this is virtual. We may have our glitches, but we'll all get through this together. Now, the reason we're all here, our speakers. We are so grateful for your time and your support. So now I'm going to move on to the agenda. So first, I'm going to let you all introduce yourselves because you'll do it much better than me. I'd like to introduce you to Maddy. So over to you, Maddy. Thank you.
Hi, and if you're able to share my slides, that'd be great. My name is Maddy Thomson and I'm a consultant nurse in palliative medicine. And one of the, I can't think of a better subject to talk about. It's a subject I'm really, really passionate, and it's about dispelling some of the myths that we sometimes hear or think about or listen to neighbours chatting about palliative and end-of-life care. And so
we'll just get the slides up.
Oh yes, sorry, I wasn't put the slides up for you so you can see them. Perfect. Lovely, thank you.
Hang on, what's happening? Oh, there we go. Right, can everyone see that okay?
Perfect.
Yeah. That's great. So if you can just show the first slide, they're not hugely technical slides, but more food for thought.
Yeah, it's not moving. Oh, there we go.
Oh, yes, it is. Brilliant. Okay. So I was scanning pictures because I wanted to find something that really encapsulated what really is the focus of palliative care. And I think it's about it's not just the meaning of life, but actually what really matters to people. So I think there's a bit of a shift change when we're under our cancer care teams. It's about treatment and it's about what we can offer. It's all about healthcare professional and what they can offer you. And I think that shift change when a patient is referred to palliative care, often alongside their oncology treatment, is actually we're talking to the patient about what matters to them and what their priorities are. And so I wanted to really just talk about, well, first of all, probably dispelling about what we talk about palliative care, which comes from the Greek word pallor, which means to cloak. So I always have this lovely feeling that, this idea that you're putting a lovely warm blanket around somebody. So there are things that we can change and there are things that we can't change in life. But we can certainly make somebody feel comfortable and confident that we're caring for them in the best possible way. And I love that image of where the origin of the word comes from. And then there's end of life care, which NICE guidance would suggest is the last year of life, but I think we talk about it day to day as referring to perhaps the last weeks of life, sometimes days. So being referred to palliative care, of course, does not mean I'm about to die. And of course, that is probably one of the most common myths that we hear. We hear that it's for you have pain, so you need to see palliative care. And of course, actually, that's a myth, isn't it? Because pain is is a part of us, but actually there is so much more to us than that symptom. So it can be many, many different symptoms. And of course, there's also our psychological well-being. There's our social care, how we operate, how we exist in society, what matters to us, our families, our friends, our hobbies, the things that we love doing, going for walks, looking at birds, gardening, playing tennis, whatever it might be. And we also talk about that existential part of ourselves, the part of ourselves that what makes us us. So sometimes we talk to people, some people talk about their faith, but we refer to we talk to patients about when things are difficult in life, how do you cope? And when we hear how people cope, we understand how that person connects with their life, and that's another very, very important. One of the other things we hear about palliative care is it's not a treatment. So it's not you're having your chemo, then you're having your radiotherapy, then you're having your palliative care. It's not a treatment. Palliative care is an approach. It's almost as if you might describe it as a mindset change. And that approach is just as appropriate at the beginning of someone's treatment for an advanced cancer as it is as they follow that journey. And actually all the better for meeting people sooner. And as I think part of this this slide is also just thinking about not just the patient. So actually looking at the patient and connecting that patient to the people that matter. So we care, I often say to people, we care as much about the patient as we do as their family, their friends, their loved ones, their cats, their dogs, their canaries. All of that matters because all of that encapsulates what matters to that person. So that's a very, very important. I'm going to go on to, if you can go on to the next slide. Thank you. So the other thing about palliative care is that I think there's a sense that palliative care equals hospice equals dying. And actually, as I'm sure some of you know, palliative care can happen in all different kinds of settings. And I think the most unusual setting was a yurt that I visited somebody in who had decided to live there for the rest of their life. And it was very nice. And when the occupational therapist told me they were a bit worried that one day they might fall out of bed, I was delighted to be able to say that that absolutely would not be the case because they were sleeping on the floor and they were perfectly happy. And that was what made that person them. So it can happen in hospices. We have outpatient clinics. We've got wonderful day settings. As you know, there are inpatient beds. There's all sorts of complementary therapies that people attend for, day treatment. So somebody might go, for example, and have a blood transfusion and then come home again. And nationally, we aim really for about 50% of our patients in hospices going home. So hospice is not simply somewhere to go and die. A hospice is somewhere where you are treated with palliative intent, and for some people, they receive care at the end of their lives. But for many, many people, they're receiving care to manage complex symptoms, and they go back home and get on with their very, very valuable lives. As I alluded to, the palliative care teams also, it's not just nurses, it's not just the Macmillan nurse that you see on telly, it's psychologists, it's doctors, nurses, occupational therapists, complementary therapists, social prescribers, physiotherapists, rehab practitioners. I'm sure I've missed people out, social workers. There are so many people that make up a palliative care team. And if we can go on to the next slide, please. You might need to click. I think you might need to click some buttons to get some pictures up. You can just keep clicking until you finish. I really wanted to give you an example of patients with cancer who are receiving palliative care. So of course we know, and some of you might have experienced care in hospitals. There's also care in care homes. That patient on the right-hand side with the dog on their bed is a patient who is cared for by a home care team at home. there are people who are living on the streets and who receive palliative care. Prisons, we have one right opposite me where I'm sitting now in Winchester Hospice. And of course, people with learning disabilities as well, vulnerable groups. So our patients come from all walks of life and are completely welcomed and embraced by palliative care teams. And it's important that they are, isn't it? Because that's what makes them them, that's where we meet them where they're at. And one of the myths is, of course, that you get referred to palliative care so that I will die sooner. Being referred to palliative care, am I going to die sooner? And there's a really interesting study from the New England Journal of Health in 2010 that compared patients who received oncological cancer treatments versus another group of patients who received cancer treatments as well as palliative care running alongside for aggressive lung cancers. And consistently, those who receive palliative care running alongside their cancer lived longer. And that study has been repeated in Japan and I believe elsewhere as well more recently. So again, huge benefits of palliative care. I think perhaps one of the most the most important things to take away from this is really thinking about living as long as possible, but as well as possible. And it's about enabling our patients to tell us how they want to live, how much of that time they're prepared to spend in hospital, what do they want their lives to look like, and in some cases to make some significant changes to their lives that perhaps they've been putting off for a while, but actually now's the chance. So another myth that we sometimes hear is we need to protect children. We need to protect children from palliative care or using the words end of life or death. But our children tell us a different story. Our children are very quick to tell us that they want us to be open. They want us to be honest. They want time. Children need time to metabolize news. They want to be able to draw pictures, to write letters, to put funny things in place, to build memories. So children consistently tell us how important it is to know what's going on. So again, not something to hide. Sometimes you hear things in the press, don't you, about eating and drinking. Patients who are under palliative care teams, oh, they just starve to death. Well, of course, that is absolutely never the case. But what we do know is that as patients have more advanced disease, it's not uncommon for them to lose their appetite. And it matters if it matters to them, and we can help them and we can use medications to help increase their appetite. But some people are perfectly happy eating less. And that's part of the natural disease process. And one of the other myths which I really want to dispel is that pain is part of dying. And really, what we know is dying is part of life. Pain is one factor. We have many, many ways in which we manage pain, and not everybody experiences pain. Of course, it's a very important symptom, just as nausea, vomiting, agitation, any other symptom might be. So I think the last slide, if you could switch to the last slide I wanted to share really, is this. And actually, it is about living every day. One of the things that I sometimes talk to patients about is that when I see patients in hospital and they're sitting in a side room, if they're lucky, or they're on the main ward, and they're surrounded by beeps and noises and smells, and actually it's a reminder of everything that's wrong. It's a reminder of their cancer. It's a reminder of the journey they've been on. And one of the wonderful things about living life as well as possible and as long as possible in the setting of your choice is it helps remind us about what's right about life, what I love about life. Just because I have a cancer doesn't mean that I'm not going to continue enjoying all of the things that make me me and remind me of what's important every day. So that's everything, I think. Thank you.
Thank you so much, Maddy. Wow, that really resonates so strongly, and it is about living as long as possible, as well as possible. So just thank you so much, really powerful. Has anybody, I'm just looking in the chat box, has anybody got any comments or questions for Maddy? But I think it's just made us all think and reflect. So thank you, Maddy. Brilliant.
Thank you. I am going to have to apologise. I've got an MDT that I need to go to fairly shortly, so I may have to pop off, but I will try and listen as long as I can.
And if there are any other questions or anything that come up as we move through, Maddy, we'll email them to you, but just thank you so much.
Oh, absolutely.
Yeah,
That'd be
thank
great.
you.
Thank you.
Thank you.
So now going to need to move to Christine and Rebecca, because Christine has been called to a meeting. So this is what I mean, we flow, we're an organic meeting. So over to you, Christine and Rebecca. Thank you. I'll let you introduce yourselves.
Hi, so whilst Rebecca's sorting out slides for us, I will just introduce myself and then hand over to her, or describe who she is, maybe, if you're busy, Rebecca. So
Yeah,
Rebecca and I work together in a PCN which is called Winchester Rural North and East PCN. So that is a group of 6 practices that go across the very rural area, the top of Winchester, and we are all small rural practices that work together, and we've added additional staff into those practices to assist with many different clinical areas, but cancer is one of them. So I'm a GP. I've previously worked in one of the practices. I've locumed in all of them, and I'm now over at a practice in Westmeath that's only got 3,000 patients. And Rebecca and I work together in the office. She is what we call a cancer care coordinator. Now, networks may call people like Rebecca varying different things. In some networks, they might be called social prescribers or health and wellbeing coaches. It's just a technicality, but what Rebecca focuses on is cancer work within our network of 44,000 patients across those 6 practices. So I'm just going to talk a little bit, and it's quite different to Maddy's talk, and I suppose it's more about survivorship and living well after cancer. But if we share our slides, Rebecca.
Has that worked? There we go.
Yeah, for some reason that's gone to the end.
Okay.
Yeah,
there we go.
and then if you just click on the little symbol at the bottom of the screen to make it big screen, that's it. Perfect.
So we were asked to talk about living well with cancer, and I suppose in my mind as a GP that is really all-encompassing, both living well whilst you're diagnosed, helping you to get an early diagnosis and the right treatment at the right time, and then actually afterwards. So many people now, interestingly, survive their cancer and may go on to have more than one cancer within their lifetime. And as GPs, I think we need to really keep that in mind. Now, I've called it how can primary care help? Because actually it's not just me as a doctor that will be helping, or doctors and nurses in primary care, but actually we've got a whole team of people like Rebecca who can help patients to do that. So I think the next slide was just reiterating who we are and what our network does. So if we can go to the next one, Rebecca. So as many of you on this group know, I know I'm absolutely preaching to the converted. Receiving a diagnosis is completely different for everyone, depending on your cancer, your situation, your family dynamic, your work dynamic. And I think that what we as primary care physicians, and I appreciate we probably cover a slightly more old-fashioned model of primary care, where we do know our patients really well. We have individual lists in our practices, and we've probably known you and your family for some of our patients still since you were born, right through to when you have your diagnosis. And that gives us a very unusual perspective, I suppose, in that for teams that meet you after your diagnosis, they only know that side to you, or that part of you. We've obviously seen you throughout your life, and to varying degrees, often with women who've given birth or come through for lots of different things, sometimes more than the men. We've helped you through a number of different aspects of your life, often before you have your diagnosis. And I think that I would like to think means that we can have a perspective of what you were like before, what was important to you before, and we often know you well enough for you to come back to us and to have that conversation in that context. So We obviously get letters about you when you are diagnosed and through your pathway in the hospital. And then what we are starting to do is Rebecca carries out what we call a cancer care review. And that happens at 2 points in your sort of journey. And it's supposed to be about being really proactive and trying to ask questions and go through a set of questions that previously a doctor may have phoned you and, you know, expressed our help and our offer of help, but may not have asked you the right questions, the questions that were important to you. The questions that Rebecca asked, she's obviously got an appointment that lasts for about an hour. She can then follow up with half-hour appointments, which is longer than you would get with a doctor or a nurse. And she can do it in a really holistic fashion. So that's not to say that there won't be specific medical things that she couldn't bring back to us, or referrals that she couldn't make to someone like a dietitian or a psychologist if we needed it. But actually, she's got the time to explore what's happening with you and your job and your children and, you know, the outside aspects of your life. I'm so sorry about my dog. So the other things that Rebecca can do probably better than a doctor or a nurse is signposting. So the holistic side of things like social work benefits, blue badges, and if necessary, DS 1500 forms and the other aspects that link in with hospice care. So for all of our patients, that should happen at 3 months, and then it will happen again at or around a year. So for some people, you'll have finished your treatment by then, but other people, you may still be going through it. So if we can go, yeah, so this is what I was saying earlier, it's really a list of all the people that can help. And I think that traditionally we have really sort of fixed ideas about what a dietitian can do, but actually we are just recruiting a dietitian into our network who is already a holistic cancer ACP, so an advanced care practitioner. And actually what she would offer you is not just about dietetics, it's so much broader than that. Physiotherapists often now can be cancer specialists, occupational therapists can be really useful, and the social prescribers and the health and wellbeing coaches can help with the mental health aspects as well. So if I can go on, Rebecca, so I'm just going to talk you through a timeline of what you might expect to happen and how that might impact on your care. So GPs obviously would hopefully be making timely 2-week wait referrals early after a presentation. But now a nurse or a nurse practitioner, a paramedic or a physician's associate may also be doing that. We would then support you through your treatment. Rebecca would then come in and she would offer an appointment proactively, and she could do that at home, on the telephone, virtually, or face-to-face. And she would be filling out a complete questionnaire about you. And then the medical issues that might come out of the information or the letters that we've had from the hospital would mean that we would want to make sure, for instance, that you were on the right medication going forwards to manage the issues that have come about as a result, for instance, of chemo or radiotherapy, but also support you in terms of when should you go back to work? How should you go back to work? Can we give you certificates that stop you having to have a conversation with your employer that you don't want to have by giving you a phased return to work, so that they by law have to support you in your return. And then I think what I'm going to talk about in the next slide is a patient, and it's the ongoing support that we can give. And this is anonymized, and I've combined a couple of different patients to give you a sort of a flavour of what sort of things we can do. So this patient actually had a cancer in her teenage years. She had what was considered curative treatment from that cancer. And I first met her many years after she had that journey. She had some surgery, and she had then had follow-up treatment with radiotherapy, and much of that had gone through Stanmore. So even though she lived in Winchester, she'd had to get to London for a lot of her treatment and missed a lot of school and exam time. So she, when I first met her, had gone back through university. She was happily married, and she had a really successful career that she commuted to London for. And everything looked to be going really, really well. She would, I think, at that stage have said that, you know, she was dealing with everything. It was in the past. And then we met again when things were starting to come up much later than maybe she had expected, in terms of fertility and the complications of radiotherapy, and issues related to that in terms of getting pregnant, and then a late miscarriage in pregnancy. And I continued to look after, you know, those issues kind of coming in and coming out. She would come back to me when things weren't going so well, or when she wanted to talk things through. She went on successfully to have babies that were then premature that I also looked after. And we supported her through that. And then when she started to get some of the more surgical complications and the mobility complications and the pain issues that happened to come up as a result of those, and when she needed to go back to Stanmore. And I think that what I saw with her was this complete journey that probably she hadn't expected, and certainly I didn't expect. But I think that, interestingly, she and a lot of other patients in this situation tried really hard when they moved house not to move doctor's surgery, just because they really like having somebody who not only has got that in the notes, so all of those things you could probably find out about her from the notes and about patients like her, but actually it's the having been there and having had those conversations and having known each other through that whole journey. So I think if we can just sum up by going to the next slide, what can we do? I think we can do different things for every patient. For some patients, we do nothing. You know, you just go through a brief period in your life that's focused on cancer, and then you go away and get on with your life. But that is probably the rare end of the spectrum. And I think that as it becomes harder to access general practice, particularly, you know, this month when it's very difficult to access general practice, don't be put off if you are being forced by your practice to go through an algorithm or write an e-consult. Actually, if you really need us, we will be there for you, and we will help you with any aspect at any point, be that 20 years or 30 years down the line. I don't know whether, did you want to add anything, Rebecca, about what particularly comes out of your conversations?
So like Christine said, I have slightly longer, so I can offer slightly longer appointments to patients. And actually what I find is sometimes the patient will sometimes be slightly more reluctant to speak to somebody else. And then what actually happens is we just have a generalized chat, and in that conversation, things come out about the patient, and we start to get to know each other, and we build a relationship. And I can help in some ways. I can go to the GP, and they actually then go, oh, actually, whilst I've got you on the phone, I was on this medication. Could you ask Dr. XYZ if that's okay, if I can continue to take this? So it becomes a more personal service for them, so that they feel that they've got a relationship with someone from their GP practice whilst they're going through their cancer. And then onwards after that as well, I go back out and visit patients who have gone into hospital and had certain treatments or surgeries, and go back out and just visit them at home and sit with them and their families and ask if there's anything that we can help with. Going forward, exercise classes, I've signposted them to things that they were doing previously that they quite enjoyed but felt they had to stop. Just giving them the confidence to start that again, taking them along, going with them. I'm quite happy to join in. And just being there, just being somebody else that they can turn to, and somebody on the other end of the phone. For the families, if mum's coming out of hospital, is there anything I need to have in place? I may not have the answers, but I tend to know somebody who does. So it's just having those signposting options and just being an extra pillar of support to the families who are going, because the families are going through it as well. It's not just the patient, you know, the families are going through it. So it's just supporting them as well, and feeling like you're doing some good for them too.
Thank you both so much. Again, it's really powerful. Now, Steve, you've got your hand up. Hello. You're mute.
Oh, I can unmute. Sorry, I thought it was centrally blocked off from me. Yeah, absolutely amazing. Thank you for that. And I think we're all going to be, is it West Meon you said we need to move to?
Yes.
Thank you. I'll start.
I'll
the
write a list. Someone
process
else
now.
has asked which practices, so I'll write a list of the 6 I cover. But in various forms, don't forget that this should be available in every network and every practice.
Yes, so that was going to be my next question. So my job is patient public involvement. So I go out and talk to a lot of patients all over Wessex. So, you know, really wide. And a lot of the feedback I get is that they really don't get the connection between primary care and secondary care. You start off with primary care often, not always the case, of course, but generally you start with that. Then all of a sudden you hear nothing. It is entirely focused on secondary care, and then pop out the end and suddenly you're back with primary care, and there is no connection between them. So I think that the model that you've got looks amazing, and I would like to be able to take that around and, you know, give that to people and say that's kind of what you need to be pushing for. You may not get offered that at your practice, but it looks like a really good normative model of what this should look like. My question though is, there's a little however in there that you don't seem to have a relationship or connection with the clinical nurse specialist, so the secondary care. So what you're offering in primary care, how does that then blend in with the professionals in secondary care who are also presumably doing some quite similar things?
Yeah, so I do meet with Vicky on a regular basis at this meeting and at the cancer operations meeting at HHFT. So we do have some link-ins. What we found was that there was some duplication when we were discussing this. You're quite right. And so there are some ways that we can make sure we're not duplicating things and sharing information better. So on your health needs assessment is the form that you use as a template, isn't it? That is also used in various hospital settings, Steve, you're quite right. And we don't want patients to be asked those twice. So we have asked for that to be sent to GP surgery, so Rebecca would have visibility of it if patients had already been asked those questions. So yes, it could be better. I agree with you. I think CNSs do pick up the phone to GPs all the time, and GPs pick up the phone to CNSs. There is something, Vicky, you'll be able to talk about this better than me, My Medical Record, which is much more of a shared, almost more like maternity notes, where there's more sharing of information, and patients can bring it up on an app when they're with us so that we can see their results in a more timely fashion with them. So I think you are absolutely right. It's not the same everywhere, and it's not as good as it could be. But we are probably working towards that ideal scenario, hopefully.
I think as well, just on the side of that, I started in March, so slowly I'm starting to build those relationships with the CNSs. So for example, just yesterday I was on the phone to one, just seeing how together we could help a patient who was just awaiting an MDT outcome. So she was quite happy to have a chat. And it's just going to be about building those relationships, I think, and making sure, obviously, like Christine said, work's not duplicated, but I'm trying to do things more holistically, and they're doing things and amazing things that they do. So it's just about building relationships, I think.
Thank you both.
Yeah, thank you. There's some really supportive comments in the chat box if you'd both like to see them, but one particularly from Fran that she'd like to share, that Mary Edwards from Wessex Cancer Alliance, who you'll know, Christine, is working very closely with many of the practices across our area and the PCNs to share and develop this good practice. And for my daughter, who I'm sure all of you know had leukemia, she very much got really, and still gets, and we're 3 years post-treatment now, really good support from her GP practice. And there was lots of linkage between primary and secondary care for her. So it is happening, and they cover thousands and thousands and thousands of patients here in Chinham. So it is happening, it is taking shape. I think it's just sometimes so frustrating. You hear about this wonderful practice and this wonderful care and service that goes on, that it isn't all out there at the moment, and it is about us all shouting out, speaking about it, sharing it, and being that voice to say, come on everyone, let's do it this way.
So these are national plans, Steve. So they
Yes,
should,
they are.
if they're
Yeah.
not with your area yet, and if you are linking with patient participation groups,
Yeah.
you know, say to your patient participation group to say to the GPs, oh, I met this really amazing woman, Rebecca, on a meeting. She's called a cancer care coordinator. Do you have one? If you don't have one, why don't you have one? Did you know that Mary Edwards has got a off-the-shelf job description, job advert? She'll help you interview. You know, the Wessex Cancer Alliance are really motivated about this, and Rebecca often talks at meetings so that people do know what she does. But not every network. There's 10 PCNs across North and Mid Hampshire. I think 2 or 3 now have got cancer care coordinators, but by no means all. You're absolutely right. But they do all have the opportunity to get funding for it.
Yeah, no, it's that's so refreshing and reassuring to hear. I know we talk about it at Chinham, so that's great. So thank you so much, and please do read through all the wonderful comments, because obviously we do need to move on. And just really grateful.
Thank you for listening.
Thank you, thank you. So now we'd like to move to Sue. Now I'm going to let Sue introduce herself, but Sue is a very long-standing committee member of Cancer Services Partnership. And so straight over to you, Sue.
Right. Okay.
You're on mute, Sue. Can you unmute her, Jackie? Just to help.
Yeah.
There, that's it, Sue. It's okay. Easy one.
Well, I thought, well, I don't know. Anyway, so public speaking is not my forte, so I apologise in advance for mainly reading it. With bullet points, I tend to go off piste and it could take forever. So I've been living with breast cancer for 32 years and counting. The first thing I would like to emphasise is that everyone's journey with cancer is their own. The longer I've lived alongside it, the research and progress that's been made have been almost unbelievable from the death sentence it once was. And I feel very blessed to be here today telling my story. A little background to life before cancer. I was happily married with 2 children, a son aged 5 who has Down syndrome and autism, and a 2-year-old daughter. Life was a challenge, shall we say, living some 70 miles from the nearest family, so very little local support. Previously, I'd done a lot of research into reflexology, primarily for my son, and how it helped your body heal itself. I quickly realised it could help many illnesses. I'm not suggesting for a second that reflexology or any alternative therapies are an alternative to mainstream medicine, but I do believe that it has a part to play in helping the body to heal itself. And furthermore, it's enjoyable and relaxing, time out spent just for you. Everyone needs to do more of that, no matter what their circumstances. When my daughter was just over a year old, prior to diagnosis, I had been on a getting back to work course. Part of it involved us writing a 5-year plan of where we saw ourselves. These were collected in and we were asked to do the same for 2 years, a 2-year plan. A bit later in the course, we were asked to write down what we would want to do if we were suddenly told we maybe had 6 months to live at best. That was like a wake-up call for me, and little did I know what lay ahead of me. So I rattled off all the places I want to see, the memories I wanted to make with my children, husband and family, and all the once in a lifetime things I wanted to experience. Whereas I'd really struggled with the 2- and 5-year plan, which like many I'd related to my career and children growing up happy and healthy. And at the end, she chose my plans to use because I'd got nothing in my 2- and 5-year plan that I had in my 6-month plan. So she said, therefore, how could you possibly expect to cram into 6 months what you weren't planning to do in the next 2 or 5 years? Life is no dress rehearsal. It's the real thing, and you only get one shot at it. She went on to say, those that leave the house one morning and have a heart attack or are in a fatal accident will never get the chance to do any of those things. So even if you have been given 6 months, you need to make sure every second counts. Life comes without guarantees of how long we have, but making sure you do everything you can to help yourself to live a long, fulfilling life by listening to your body and acting accordingly. Keep hydrated. Water is the elixir of life, and sleep is when your body heals. Don't fight it. Another salutary lesson that I've spent from that day forward doing just that, and I have been ticking off my wish list one by one ever since, with a new sense of priority of what really makes me get out of bed in the morning. I can still recall the fateful day I took my son to see our GP in 1990. He'd had a cancellation of the following appointment, so asked me if there was anything else he could help me with, to which I responded, I'd found a tiny pea-like lump in my left breast. He was exasperated with me that I put everyone else before myself. Long story short, despite my protestations that it was probably a blocked milk duct or something, thankfully he decided to refer me to Mr. Rees, who at that time was a general surgeon. What a stroke of luck that was. Stage 4 breast cancer was diagnosed, and he said I needed a lumpectomy followed by radiotherapy. As I was young, I thought saving my breast was the most important thing. You live and learn. He very kindly asked me when I wanted to come in for surgery, to which I replied, the school holidays are starting next week, which are a massive struggle. So I'd need the first week of September to recover, to be in the best place for an operation and get some care for my son and daughter organised. Mr. Rees asked me if I'd heard my diagnosis and patiently repeated it to me. Unfortunately, the longer-term diagnosis was not great, as the type of cancer I had was like a meteor dropping tiny cancer bombs like a shower. I was not expected to see my daughter go to school. Therefore, the sooner he operated on me, the better the likely outcome. He pulled no punches and asked if I wished to be around just for this summer holidays or for a few more years of both my children's lives. This was my reality. He then told me he would add me to his list on the Monday morning. That day was the Friday before. Not being there for my children was not a prospect I felt I could even contemplate. And with lots of tears and anger, juggling, it happened 3 days later. At the same time, I set about wondering what I could be doing to try and redress this balance and increase my chances. As soon as I recovered from surgery and radiotherapy, which in those days involved daily visits to Southampton, numerous machine breakdowns, and therefore wasted trips, we set about making memories and taking advantage of every opportunity that presented itself. I started having reflexology for myself and continue to this day, always alongside conventional medicine. For the next 6 years, I defied predictions, and we started ticking things off my wish list that were achievable both financially and practically with a young family, making precious memories. It began when my GP made it clear to my husband and I that unless I dedicated more time to focus on myself and not put everyone else's needs ahead of mine, I would no longer be there for anyone. Another wake-up call. So I went to visit a good friend in Washington, DC in America on my own for 2 weeks while my husband cared for the children. It took some pre-organisation to make it happen, but where there's a will, there's usually a way. Inevitably, with my type of cancer, it returned in the same breast, but in an entirely different format. On that occasion, I had a mastectomy and reconstructive surgery in one very long operation. Again, 26 years on from that surgery, the transformation in this type of operation, and hence the recovery period required, is quite remarkable. I had months of chemotherapy following the surgery. Another wake-up call. Every day is precious in its own right. So the memory banks needed to be upgraded. We couldn't afford Florida, but Euro Disney had just opened in Paris, which we could afford in a freezing March. Well, you have to cut your cloth, as the saying goes. Don't waste time dwelling on the negatives. At the ages my children were, it ticked all the boxes. And so life carried on from scan to scan, making more dreams become a reality for another 6 years until 2002, when I was diagnosed with bone lesions, not to be confused with bone cancer, for which some bones can be replaced, supported by surgery, but still came with a 10-year max diagnosis. And the aim is stability with no new lesions. so definitely living with cancer now. The treatment required 2 infusions every 3 weeks, as my cancer had morphed itself and was no longer estrogen based, but HER2 positive. Another curved ball to face. Herceptin at that time was the postcode lottery drug, and famidronate, a bisphosphonate, that also came with side effects to strengthen the bones. However, having been told that I fitted all the criteria, this being my 3rd foray with cancer, and that Herceptin was the new targeted wonder drug we'd all been hoping for, I recall going to this appointment with my oncologist alone, expecting it to be a formality of sign here, as it was newly approved by NICE, if you matched the criteria. Instead, I was told, unfortunately, I didn't fit the criteria after all, as you needed to have had a particular cocktail of chemo, which wasn't even available when I received mine. So I said, well, if that's the only way I can have Herceptin, I'll do that. Not an option, I was told, as it was unethical to prescribe it when it would not help me for bone lesions. And to this end, she'd booked me into radiotherapy, which wouldn't really help, after my return from a family cruise to celebrate our son's 18th birthday. To which I responded, you may as well tell me to go away and die quietly in the corner, which I can assure you is just not an option for me. I recalled Dr. Brain at the outset. In order to be there for anybody, you first need to focus on yourself and not try saving the world, else you may die trying. You need everything you have to fight your own battle with cancer in order to have the wherewithal to help others in the future. Hence why I've been sitting on the Cancer Services Partnership Committee for several years. So with all Dr. Brain's best efforts to secure Herceptin for me failing, I turned to someone else I felt I owed my life to and asked for help. I returned from holiday, having taken advantage of the cruise photographer to take some wonderful photographs in case they were my last. To the good news, radiotherapy had been cancelled and I was starting with Herceptin on Thursday. I was fortunate, and it was the exact drug that could help me maintain my status quo. So life then had to fit in around 3 weekly treatment, followed by reflexology with a day or so before or after to prepare the body, and a couple after to get over the side effects. Others wonder how we manage, but you only get one life. So for us, it was a no-brainer. Our whole life gets organised around it, and we remain forever grateful. That regime continued until 2015, when an injection version was approved by NICE, which replaced the infusions and made the difference between several hours up at the hospital to less than an hour. There were times over my journey when I often reflected on the fact, for many, the last thing it was NICE, when they decided you didn't fit the criteria to receive the only drug that your consultant believed was the most likely to save or prolong your life. Sometimes you just have to believe and trust and learn how to literally fight for your life. So I am now just over 20 years into my latest outbreak. I have not only been blessed enough to see my daughter go through all her schooling, receive her university degree and qualify as a primary school teacher in 2009, I've seen her marry and provide us with 2 wonderful grandchildren with whom I cherish every minute I spend. My son will be 38 in February. He lives in a residential home in Southampton, but is still very much part of our family. He comes home often, has been on many more cruises with us, and treasures being an uncle. There have been many battles that we've had to fight on his behalf along the way, and many more ahead, I fear. So no giving up yet. I no longer worry about being sent scan appointments. As I've always believed, the sooner you know there is an issue, the quicker you can reactivate your private inner army of cancer soldiers to annihilate it, which I still march in and out during sleepless periods. The mind is such a powerful part of my private battle with cancer. And I have developed techniques to deal with unpleasant procedures and sleepless what-if scenarios. For me, the worst bit of any of it is having had the scan, the dreadful wait for results, and knowing that someone else knows your fate, but you don't. I feel sure many of you can relate to that. When people ask me what it's like living with cancer all these years, they're usually shocked by my response. I feel blessed. I strongly believe that fateful diagnosis changed the path of my life would probably have taken for the better. And instead, I've lived my life to the full and thankfully continue to do so. What has been different between myself and others who have been part of my journey, but who are sadly no longer with us? For me, being a control freak, I never felt like I could take the diagnosis on the chin and believe in miracles. For me, I've found people tend to help those who try and help themselves. We all get curved balls along the way, me more than most, but it is how you choose to handle them that gives you back some control. I've owned the cancer, listened to my body, challenged decisions if I felt I needed to. I continue to keep abreast, pardon the pun, of as much research as possible, and have 3 weekly reflexology following my treatment cycle. For me, keeping hydrated with water, exercise that works for you, sleep if my body tells me to, whatever time of day or night, all contributes to my well-being. I have long since completed my original wish list, included many more along the way, but I always have something to look forward to each day, each week, each month, and then a bit longer term. For me, that is a cruise with our son Jonathan in May, and longer term, a trip to Japan to see the cherry blossom in 2024. I've been truly blessed to have had the most amazing GPs, consultants, and subsequently the whole acute oncology team to turn to if required in an emergency. And the CNSs, in our case, cancer specialist nurses, over the last 10 years maybe, who have always listened when I needed them to, and have often gone over and above their remit to assist me to turn a dream into a reality. Not to mention a wonderful husband and family there to support me all the way. Life is a gift that should never be taken for granted. Metaphorically, say no to cancer and use it as a wake-up call to live your best life. One final point, travel insurance, an ongoing crusade of mine. I know more about what is going on in my body than 99% of travellers that get insurance at a fair cost. I get penalised for sharing my life with cancer. Has it stopped me? Hell no.
Wow, absolutely. Just thank you. So that is just, I don't think any of us can underestimate the power of hearing someone's personal experience of moving through cancer and living with cancer. So thank you. And I look forward to seeing those photos and hearing about the cruise in May and the blossom next year. So thank you. And there's some lovely comments in the chat box. Are you able to see them?
Yeah.
Yeah. So Christine, I know Christine has got to go to a call soon, and she very much says thank you for sharing. As a parent, as she is a parent of a child with special needs as well, and hearing your amazing 20-year story is I would assume very humbling, very humbling. So thanks, Sue, as always, just thank you. Okay. Yeah, so well, I'm going to say to Alison now. So I'm going to introduce Dr. Alison Farmer. I'll let you do the full introduction, Alison. So sit back and relax now.
Oh, good. Thank you.
I'm just going to try and share my screen. Typically, it was there a minute ago, wasn't it? Now I can't find it.
Don't worry. Jackie's in the background to help if she needs to.
Yeah, there's slightly different slides. Why is it vanished? That's very bizarre. I've got it minimized. Just give me a second.
Okay, that's okay. Just remember as we move through and listen to our speakers, if you've got any thoughts that pop in your head, just pop them in the chat box and we can always share those. So great.
That's really peculiar. Am I on share?
Yes, you are. We can see your screen with Zoom through the middle. So if you can access your presentation where you've minimized it to.
Yeah, no, it was there when we had a practice earlier. Now it's vanished.
Not to worry.
really peculiar. Let me try and go back to
And these things always happen.
Hmm.
okay, I think you'll have to.
Is it in the PowerPoint icon at the bottom of the screen there next to the Zoom one? Is it in there? That's it, where you were just there.
Will that
Yeah,
show?
there we
Can you
go.
see that?
There we go. That's it. Yep.
Oh, amazing.
Yeah.
Okay.
So if you just click on, that's it, little toilet system. Perfect.
Miracle.
Good.
Okay. So firstly, thank you so much for sharing that, Susan. That's a really powerful story and will give lots of people lots of encouragement. I think you're a perfect example of someone who's living well with cancer. So I just want to introduce myself. I'm a psycho-oncology nurse at Southampton University Hospital, and I'm probably the only one in the country doing exactly what I do, which is to support inpatients who are distressed as a result of their diagnosis and treatment. I wrote a job description many years ago because when I returned to nursing after teaching at the university, I noticed patients were very distressed, and as I had 10 bags of chemotherapy to hang, I didn't have time to support them. So I've now been doing this job for 7 years, and it's an incredibly rewarding job. And when I was asked to speak today, I was thinking about how I would approach this subject. And I thought the best thing was probably just to talk about some of the things patients say to me and how I might respond. You know, it's not perfect. There are other ways of doing it, but just thought to talk a little bit about the conversations I have every week with patients. So here we are. Just trying to minimize that. That's better. So as Maddy said, a referral to palliative care, this is often what patients say to me, a referral to palliative care means that I'm dying. And as she said, that the definition of the word palliative comes from the term to cloak. And I agree, that is just such a lovely, warm, supportive term. And I think I often will say that to patients. I will give them the meaning of palliative because it just sounds so lovely. People have an image in their mind of palliative care, as she said, of being something you go to at the end of life. But it's really, really important to emphasize that palliative care should probably be introduced right at the beginning of the diagnosis for many people. And having that connection with palliative care over many, many years is quite common. And if people do start to come to the end of their life as a result of cancer, if they've had that connection with palliative care over the years, it makes the final aspects of their treatment much easier. So that is a very, very common myth that it's important to dispel, but I won't talk much more about that because Maddy has covered it. Oops. So another thing patients and staff and relatives say to me is that patients don't want to know their prognosis. This is, again, quite common, and it can be quite frightening if to know really that maybe you've got months rather than years, for example, to live. But it's really important if relatives are saying, particularly, I don't want you to tell mum her prognosis. It's really important that we gently point out that it is the patient's information and they have the right to know. And actually, research suggests that about at least 80% of patients want to know everything about their diagnosis and their treatment, and they want all the information. And in a study by George et al. Looking at accurate prognostic understanding, they found that patients who have a good understanding of their prognosis have initial sadness and distress, but this doesn't last. And often knowing the full prognosis does lead to improved well-being. And it gives the opportunity for us to have those open, honest conversations about what is important to the patient, what their preferred place of care is, preferred place of death. It gives the patient some control over their illness. It gives them the opportunity for advanced care planning, which is so, so important. The opportunity to fulfill wishes, as Susan was talking about, having that sort of bucket list of things that you want to do. And the opportunity to partake in treatment decisions. So there's lots of reasons why having that accurate prognostic understanding is really helpful. And the research has shown that giving patients unrealistic hope actually leads to eventual psychological decline. So it's not good for us psychologically to have that unrealistic hope. So although there might be initial sadness when we talk about prognosis, in the long term, it is better psychologically. As Maddy pointed out as well, that a lot of patients will say to me, oh, I don't want to go to the hospice. You only go with a one-way ticket. And we do know that that is absolutely not the case. And I know she's covered that in great detail, but people do spend many years in contact with the hospice and do get those benefits from the additional services, you know, not only counselling and psychologists, but support groups. You know, at Mountbatten House, they have a build and banter male group, for example, and all sorts of things that you can go and do and enjoy and share your experience with other patients. And going into a hospice for respite is also quite an important aspect of hospice care. You know, maybe it's to give a relative a break, or just for you to have a break from being cared for by your relative, if that's the situation. So all sorts of reasons why hospice is not a one-way ticket. People often will go in, have their symptoms controlled, maybe have a rest, and then go home again. One of the things that patients have said to me in the past is that everyone who gets cancer dies from it. Now, this is really difficult if you've been diagnosed and this is your if this is your belief. And I would always look at evidence for that. So, you know, ask the patient, what is your experience of cancer? And if they say, well, my mum got cancer and she died, and then my cousin got it and he died, and everyone they know has died from their cancer, then they will have, it's an understandable belief, isn't it, that everyone dies from it. So exploring what their experience is, because we know that if past experience of cancer and how our friends and family have, whether they've survived or not, will impact on our own adjustment. So that's the first thing to ask. And then talk, well, who do you know that might have survived cancer? And often people can think of celebrities. For example, Kylie Minogue, who was diagnosed with breast cancer many years ago. People can often think of people who do survive. We know there are many, many, I think 2.5 million people living with cancer in the UK at the moment, which is rising all the time. And at this point, I might say, and I very rarely tell patients that I had ovarian cancer 21 years ago, but that is the only time that I might actually share my experience of cancer if they strongly believe that nobody could possibly survive 20 years. This is extremely common. I'm frightened of recurrence. Now, many patients, in fact, I can't think of anyone, even with the most early curable skin cancer, for example, who doesn't have the thought that their cancer might come back. Fear of recurrence is extremely common. For about 10 or 11% of patients, it can be quite disabling and can either lead to heightened checking, breast examination several times a day, Googling, ringing up the clinical nurse specialist or the GP for advice to manage that fear. So very, very hypervigilant and frightened. Or it can have the opposite effect in some people, in that they will actually avoid going for checkups, avoid going for blood tests or follow-up scans. won't read any articles or watch any programs about cancer. So, but that's only, as I say, around 10% of patients, but it is important that we're aware of them. I will encourage staff to talk about fear of recurrence, because even if the patients don't mention it, that fear is there and it's extremely common. Over time, it becomes less powerful. You might not think about your cancer every day. You might start by thinking about it once a week and then once a month and then eventually go for many months without thinking about it. But just to let you know how powerful it is, I recently started running a bit more, got a niggling pain in my abdomen, and went along and asked for a CA-125, and that's 21 years after my diagnosis. So it never quite goes away that when you get an unusual ache or pain, you think that your cancer may have raised its head again. So I always do, as I say, encourage people to talk about, staff to talk about fear of recurrence, because it will be there. And I will say to patients, just sort of notice what your brain is doing, stand back a little bit from your brain. And just by saying the words, oh, I noticed there's my recurrence story showing up, or I noticed there's my cancer story showing up again, that can be helpful. It can just make those thoughts less powerful. And encouraging patients just to use something like mindfulness, 5 to 10 minutes a day. I'll give them a mindfulness script, maybe mindfulness of breathing, can sort of help train the mind to be more in the present moment, because it's very easy when you're diagnosed with cancer to get hooked by worries about the future or regrets in the past. But with something like fear of recurrence, just coming back to that present moment can be very helpful. This is a really common thing for patients to say to me. Probably once a week, someone will say, I'm frightened of dying, and it's absolutely understandable. What I would start with when patients say that, you know, most of my job is listening, validating patients, holding that distress, and that's really important to spend lots of time doing that and just listening to them. But when the time's right, I might say, tell me, what is it about dying that you're frightened of? And often it's one of two things. One might be my family won't cope without me. And I'm going to talk a little bit more about that. The other thing is they're frightened of the actual dying process. You know, what dying is like, because as health professionals, we take it for granted. You know, I've been with people, I've had the honor really to be with many people who have died. It's a very intimate experience. It's an incredibly powerful experience to share with someone that you've looked after. So I know what normal dying looks like, but I might say to the patient, if they say they're frightened of the dying process or they're frightened of dying in pain, I will say, would you like me to explain what normal dying is like and how we manage end-of-life care? And I have done this many, many times. And the biggest honor, or the best day in the office for me, is when people say you've made dying less scary, just by explaining how we manage that end-of-life care. Sometimes I will show them this excellent small video by Catherine Mannix, the palliative care consultant. You can Google it. It's called Dying Isn't As Bad As You Think. It's just 4 minutes long, and she very gently explains what normal dying is like. So I will either watch it with the patient or give them the link. People have said to me, oh, that's reassuring. I now no longer need to walk into the sea when my cancer gets worse. So finding out what people are afraid of is incredibly important. And the my family won't manage without me, again, is an understandable concern, particularly for people who sort of manage the family. You know, the matriarchs often really struggle. They're looking out for their children, they're looking out for their partner. They love that role. It's very, very important to them. And that's a very understandable concern and very distressing for patients. But again, I will ask, just sort of like taking the skin off an onion, they're just gently peeling those skins off until we find out exactly what it is that concerns people. And I might look at evidence for that thought. So let's look at evidence for the thought that the family won't manage. And I always get the patients to come up with the evidence. So they might say, well, my daughter's depressed and she's not managing very well with her children. She needs me to help her. She can't afford childcare, so I do that. And the patient might come up with 4 or 5 reasons why the family won't manage. But then I'll say, okay, let's look at evidence why they might manage. And who else is there to support the family, for example? So the patient might say, well, my daughter has depression, but she is getting treatment for it. And there are other cousins and siblings who have offered to help. You know, my daughter's a really good cook, so she can manage in that department. And so it doesn't take that fear or that worry or that concern away, but it can make just looking for evidence for and against can make it less powerful. So that's a technique that I sometimes use. But again, not invalidating that thought. It's so important that that is a very valid and very distressing concern. This again is really, really common, and it's one of the main reasons that patients want to hasten their death. And they say, I don't want to be a burden on my family. And this is a really, you know, again, a very distressing feeling. But again, I might gently say, how would you feel if your sister was in that bed where you are? Would you feel that she was a burden? And of course, 9 times out of 10, they would say, no, absolutely, of course not. I absolutely want to be there for her. And then I don't need to say anything else because they've really answered the question. And again, it can help to look for evidence. Okay, so I remember doing this at Mountbatten House with a patient who said, I'm a burden on my family. I said, look for evidence for that. And she said, well, I can no longer run around after the children. I can't do the housework. I just sit on the sofa all day. My husband has to drive me back and forward to the hospice. And I said, well, let's look at evidence against you being a burden. And she thought for a while and said, well, no one said that they don't want me around, and I can still snuggle up on the sofa and help the children with their homework. My husband's not said that he minds driving me around, etc. And that she initially thought that belief to be 80% true, that she was a burden. And by the end of it, she said, oh, well, it's more like 50% now. So again, it doesn't take that worry away, but it does make it less powerful. So I'm a big fan of looking for evidence for and against a thought, because thoughts are just often unhelpful. They're just words and images. They're not necessarily facts. So I might do this when I'm driving home. I think, oh, that was a really bad lecture. And then I'll look, well, let's look at evidence for and against. So try that yourself. It can be a really helpful technique. And another common thing that patients say to me is, I can no longer do the things I used to enjoy. And they're grieving over the loss of those activities. But again, it's a simple simple way is to just, explore what is it about, for example, gardening that you really enjoy doing. Is it about the physical activity of double digging the allotment, or is it about sitting in the deck chair talking to your friend at the allotment, the companionship? Is it the joy of planting a seed and seeing a small plant come up a few days later? What actually is it about that activity? And patients will then, together we can think of ways that they could still enjoy that activity, but maybe not as physically. So could they still plant a seed tray or a hanging basket? Could they go to the allotment and just sit and chat to their friends while they worked? And recently I was talking to a patient who was very sad about not being able to play tennis anymore. And again, we explored, what is it about the tennis? And it turned out that the thing she loved the most was the companionship. of her friends. So she actually said, do you know, I could just go and sit and watch them and still join them for a drink afterwards. So it's always worth exploring with patients exactly what it is when they're telling you some of their worries and thoughts, sort of peeling that onion and getting to the bottom of it. And I think really the message is that you can't get rid of your fears, but you can learn to live with them. They're very normal, but if we make room for those difficult thoughts, emotions and sensations, and sort of drop that struggle with them really, rather than trying to push them down, stick them in a box, just notice, oh, there's my cancer story showing up again, and just lean in and still do something that you value. That's the most important. And I think that's the end really of my short session.
Wow, thank you, Alison, but not the end. There's such invaluable suggestions there, and it's just so refreshing to have such an open conversation about all of this. I mean, crikey, so often everybody just mutters things and then disappears, but it is so key, isn't it? Absolutely. I'm just looking in the chat box. Christine has said about, it's absolutely very true about reoccurrence. It almost does stop people and they avoid screening as well. People are just saying, thank you. That's a good way. Bridget has said this is such a delicate, intricate dance that Alison describes. Yeah, absolutely. It's so true. So thank you. Thank you so much, as always.
It's a pleasure.
So deep breath. There's lots of things to hold on to there. So now I'd like to move over to Claire. So Claire, welcome. And I'm going to let you introduce yourself. Claire is a dietitian, but you go for it, Claire.
Thank you. Eileen, can I just ask first, how much time do you think I have with the number of people that you have left?
Yeah.
And the session we're finishing by 12. How much time would you like to allot me?
Yeah, we are watching the clock closely. So it's 10 minutes, okay?
Yes, I can do that.
Thank you.
Jackie, could you pop me on to the presentation whilst I introduce myself? So hello everybody, my name's Claire Gill. I'm the Macmillan dietitian for Hampshire Hospitals. I'm actually sitting in the corner of an OT physio kitchen. There's nobody else here, but I was very concerned about my access to IT. Hence what I've done is I've put quite a few overheads up. Oh, let me just plug myself in, hold on. Oh. My plug's not working. I thought I had myself plugged in. Hold on a moment. I'm just going to have to move my computer.
I know I have to keep checking that I'm not going to run out of power.
Aha. So, right, I've had to move. I thought I'd been plugged in all morning, but I clearly hadn't. Right, hang on a moment. Let me just...
Okay, just get yourself comfy.
Right. Okay, I'm by the exercise bike now. So thank you. Jackie, is it okay when I say next slide? Is that all right? Thank you. So my name's Claire Gill. I'm the Macmillan dietitian for Hampshire Hospitals. We are a very small, very small number. We are just 1.35 whole-time equivalent dietitians when we are fully staffed, and we're not fully staffed at the moment. And I really want to talk to you about helping to live well. Now, as those of you that know me know, I could sit and talk for hours and hours and hours just on dietary myths or just on palliative care and nutrition. And if you talk about nutrition, it is an absolute passion. And the reason why is that it's different for everybody and everybody has an opinion. Some things people don't necessarily have opinions on, but often everybody has an opinion. So if we just go to the next slide, Jackie, just so that in case if I do lose, because I'm currently sitting on one of those patient examination couches, so I'm trying to get my computer right. So, and I do feel very honoured to be talking at this point because there have been so many fantastic speakers. Sue's presentation particularly really touched touch so many points, and I will be referring to what she says as well. The thing about that diet and nutrition is that it can help people to eat and live as well as possible, and that we as healthcare professionals need to really, really listen to what's important to people. Some people may be very, very, very interested in the dietary choices they make, and so it's very important that they have very fine control over the food that they choose. Other people may not want to have that involvement. But as Maddy said right at the beginning, healthcare professionals really need to listen to what our patients and our carers want. And living well, as many of the previous speakers have said, does mean different things to different people. So, for example, I know that if my colleague next to me has an egg and cress sandwich, she's going to love it, absolutely love it. She's going to close her eyes and that pleasure. Whereas I'm going to sit next to her and go, I need to get out of this office because I can't bear the smell of egg. It may be a fantastic, fantastic nutrient with vitamin D, protein, things in it, but it means different things to different people. So to me, if I was unwell and was given an egg, I really wouldn't feel that I was living well. So living well means different things to different people. And this is the thing really I want to focus on. The fantastic thing about food is that it can empower the person with cancer. So Sue referred to when she was first diagnosed, how the diagnosis was given to her. She was asked when she wanted surgery, and then the reality hit of actually you need surgery within 3 days. So that empowerment was understandably was taken away to a certain extent. And the fantastic thing about food, it can give you that empowerment. Most of the time you have a choice as to what you wish to eat. But again, the thing about food and nutrition is that we can support the caregiver, because the caregiver is often the one that provides the food, and they have an opinion about diet as well. Could you go to the next slide, please, Jackie? Lovely. So what do we know? Well, we know that food elicits different emotions. People have very strong, often beliefs on what is right and what is wrong, and that is absolutely fine, but everybody has different opinions, and trying to find your way through that process can be very difficult. And if you Google diet and cancer, you will come up with 2 million results, and some of them may be misleading and may be unsafe. So how do you find your way through that? So that's really what I want to talk about in the next few minutes. What we know is that, again, Maddy referred to this a little bit, in that early intervention can be helpful to enhance quality of life. So if there are any dietary queries or questions, or somebody's beginning to lose weight right at the beginning of their diagnosis, if we can help to support that at that point, that's great. And early intervention can be very helpful. Weight loss and appetite loss towards the end stages isn't necessarily controllable and can be a normal process of dying. So it's when to seek that support. So what we know is that early intervention towards the earlier stage of palliative care can help from the point of view of giving more nutrients, but there are so many other things as the disease progresses and as you get towards the end of life. Can I go to the next slide, please, Jackie? So what are the common situations? Sorry, I just had to, the table wobbled a bit. So people feel that there are foods and drinks that are bad for me. And as Alison was just talking about, that pleasure, that enjoyment, but feeling that something that they enjoy is bad for them gives them real conflicting emotions. There's also often a perception that because I as the patient cannot be persuaded to eat anything else, or like I don't want to eat anything else, there's a real atmosphere. Because I'm maybe letting my caregiver feels they're being let down, or I feel I'm letting my caregiver down because I can't eat what they want me to eat, or I can't show my love in the way by eating the food they prepare. It's a really, really interesting situation. And people often feel that if they eat better, they then reward the person that is living with them, that is their partner or their carer. And also that perception that to be a good relative, loved one or carer, I need to encourage my loved one to eat the right things, and what are the right things, and all goes around. So that's what I want to try and get into and try and dispel some myths. Jackie, could you go to the next slide, please? So foods can make You feel emotions through sight, smell and taste, as per my egg scenario. So the tomato soup. So I can see Eileen having a bit of a smile when that came on. I know I'm picking on you in particular. If I was in a group of people, I would, what does tomato soup, which may be a specific make of tomato soup, what does it remind you of?
It makes me feel cozy and comfy and reminds me of my mum.
Absolutely, absolutely. And that's how it feels for you.
Yeah.
And many other people say that. But interestingly, my husband, you show my husband that and he'll go, take that away. I can't bear the slimy smoothness of it. There's no bite in it. So it gives him real strong emotions. But I could see the minute we put it on the screen and it gave you emotion. And when we're doing this in a room, you can see that as well. So food can make you feel. It's not just the nutrients. And that's really important in palliative care. Can you go to the next slide, please, Jackie? So chocolate. So I won't, obviously, for time's sake, I won't go through everybody and say, what do you think? No, I love the way chocolate feels in my mouth, but I know for some people, it can give them a great sense of guilt. I've been overweight all my life. I have been restricted. I've been told that chocolate is bad for me because it makes me put on weight and it's high in sugar. But I love it. All these conflicting emotions. And actually, if we get down to it, when we try and break down why they're restricting what they're eating, it may be because they feel that I need to lose weight. At this point, do you need to lose weight at this point? Is this what we're looking at? If your diabetes is well controlled, a small square of chocolate with a meal is completely acceptable. If your cholesterol levels are raised, are we actually looking at trying to reduce them, or do we want you to get the pleasure? And if you get pleasure, you tend to perceive pain less, you tend to be able to cope better with side effects. And I put a little tot of whiskey there, although I find it difficult with the smell of whiskey. My father, when he was very unwell, you would literally bring the whiskey towards him, and even if he couldn't drink it, he would smell it, and the pleasure on his face, that look on his face. So it wasn't even ingested. It was, he relaxed and he was visibly in less pain simply from the smell of whiskey. So it is a very, very strong thing, food. Jackie, could you go to the next slide? So mint sauce. So mint sauce with a meal reminds me a little bit like what Eileen said about sort of being with her family, friends. It's about being together with your loved ones. So a little bit of mint sauce on a plate can take people back and can give them that comfort and reassurance and good memories. And that's what food can do. And that's why food is such an important, such a strong thing. Can you go to the next slide, please, Jackie? So what does it mean to you? It means something different to everybody. It can mean comfort or pleasure, or displeasure, conflict, guilt. It can mean loved ones with family. It can give you happy memories. It can give you bad memories. Me and the egg. Don't come near me with an egg. It can give you hope. So some people feel that if they're able to eat and they're able to eat a balanced meal, it gives them hope that they're feeding their body good nutrition, and that gives them some strength. And that's the same sometimes with a bottle of supplement drink. Some people who really struggle with their eating find that a bottle of supplement drink, when they can't manage anything else, gives them some pleasure. I've been able to take this, I've shown my loved one that I'm taking it from them, and it gives me some hope that I'll have energy in my brain to be able to say what I want to say. So there is lots of things. So also it can be self-action. People can choose to eat and choose not to eat sometimes, or choose to use it to fight a disease, and they are all very, very valid. And also, obviously, food. As a dietitian, I'll look at something in a chill cabinet, and almost in my head, I go protein, calcium, zinc, all these things come up in my head. But that's just me as a dietitian would do that. So it means different things to everybody. Next slide, please, Jackie. I could have spent a long time just talking through certain myths and trying to dispel them. But what I've just done is I've just chosen 5 here. Now I can, I've got some links later on where you can get further information on these, but these are just some very common facts that I find that people sometimes have read and they've been misinterpreted. So Sugar feeding cancer, that's a very common thing on the internet at the moment. Interestingly, if we cut out sugar from our diet, it doesn't restrict the delivery of glucose to the cancer cells. I'm sorry, I've got the bracket in the wrong place. It doesn't restrict the delivery of of glucose to cancer cells, because interestingly, protein can eventually be broken down to glucose and can feed the cancer cells. So that's been slightly taken out of context. However, what we do know is that if people are very overweight and they are at the beginning of their cancer journey, helping them to keep their weight under control is helpful. However, what we know is that the body will find glucose, and every cell needs glucose. Hormones in dairy. If we look at the British herd of cows, there isn't a link to hormones and cancer. However, people may have their own wish and their own beliefs, and that is absolutely fine. And what we would say, if somebody was going for plant-based milk, we'd say, make sure it's got adequate calcium in it, or that you're getting your calcium from somewhere else. Superfoods. Superfoods are a really interesting thing, aren't they? The reality is that superfoods is a group of foods that claim to have health enhancing benefits. The reality is that it's the variety of food that's more important, not just one or two specific foods. So if you want to include those superfoods, that's absolutely fine. You know, there's a good balance, but try and have it as part of a balance. If you're feeling that that's the only thing that you should be eating, or you should be having it every day, and it's making you unhappy and you don't like the taste of it, then you don't need to have it. The burnt food question, that's been going on for years, hasn't it? There's no strong evidence, but there are some unanswered questions about that. So we generally say aim for golden brown. The alkali diet, again, is an interesting one. And what we know is that the blood pH, so the acidity or alkalinity of the blood, isn't altered by the diet, because the body has such a good regulation system. You can change the pH of the urine, but you can't change the pH of the blood. And interestingly, healthy cells can't exist in an alkaline environment either. So we probably need to do some more researching on that. But the basis is a variety of diet that you enjoy. Next slide, please, Jackie. So this is where to find your advice. So you can obviously, if you have a CNS or a healthcare support worker, you can go to them for advice. As Eileen and the CSP picked out very recently, there aren't very many dietitians, and I know they're obviously the Christine and sorry, was it Helen, Hannah? I don't have my notes on me. I do apologise. They have a dietitian there, which is fantastic. What HHFT have done, and it's this next in the third point, we have produced a tool that you can access 24 hours, 7 days a week, and you can go into that. You can screen yourself with nutritional questions, and we have put together good sound resources from a variety of areas that you can click onto as well. So I do encourage you to have a look at that. And I've also put some links from the World Cancer Research Fund, from Cancer Research UK and the British Dietetic Association about particularly the myths and because otherwise I could be here for hours telling you about different foods. And what I want to do is give this a platform to enable you to answer those questions. Next question, please, Jackie. Sorry, next slide. So in summary, what I want to do today is to help post people towards good, sound nutrition information and dispel any myths about eating and nutrition. If somebody wishes to follow a certain diet, that is great. They've got empowerment. But what I want to make sure is that they are happy with the dietary choices they make. And those websites may be able to help, and your healthcare professionals might be able to point you in the right direction. Do I need to restrict food I like? Very infrequently. Very infrequently do you need to restrict food you like. If you have an obstructed bowel and you like to eat nuts, you are likely to get symptoms from that. So in some situations we might advise against certain things, but if it's a pleasure principle of sugar, of fat, of a little bit of alcohol, it's about the pleasure and how it makes you feel. What we want to do is help people to deal with their emotions surrounding foods, and it's okay to talk about those. It's okay to have emotions about food, and also to balance your carers' feelings about food as well, because they are real. Providing relief from distressing symptoms is something that palliative care is all about. And at the end of life, food can help with that as well. So somebody is getting symptoms of a bowel obstruction often, and we go through their diet and we find that actually some foods are increasing the pain. We might advise to avoid certain things, but that's to avoid those distressing symptoms. So that's really about today. Next slide, please. Thank you so much for your time. I hope I'm in time. Eileen, I had to move away from my clock, so I don't know what the time is.
Yeah, absolutely fine. Just thank you so much, Claire. And the information and those points in your slides are invaluable to be able to take away and share.
That's what I want.
And absolutely, that's perfect. So thank you very much indeed. Okay. And there's some thank yous popping up in the chat box. So obviously we are very conscious of time. So we're going to move swiftly on to Olivia, please. Hello, Olivia. And Olivia's going to share with us as a physiotherapist. So I'm going to let you to introduce yourself, Olivia.
I will do. Thank you. Sorry, I've just need to find my right view now. Can you see the presentation? Because I've seemed to have lost all of you. Yeah. Okay, that's great. Let me.
Yeah. It's not full screen, but it's fine.
No, that's what I'm just going to press on.
Yeah, it's fine.
There you go. Thank you for inviting me. So my name's Olivia Birch, and I'm a Macmillan physiotherapist, and I work in Portsmouth. And I'm very aware of the limit of time, but I will just share with you. I work basically within a specialist palliative care team in Portsmouth, and we'll go into a bit more detail on that as we go along. Now, obviously, we've had some speakers that have been talking about what palliative care is, and I think the most important thing is, as a physiotherapist, or as some people might refer to me as a physioterrorist, obviously my focus is on people's physical well-being, but I wouldn't be able to do my job if I wasn't taking into considerations people's psychological needs, their spiritual needs and their social needs as well. So as a palliative care physiotherapist, we really look at the person as a whole. And going on what Maddy was talking about earlier, we see people who may still be having oncology treatment, but where it isn't with curative intent, and we may be seeing people who still have years of life, not necessarily within their last months or days or weeks. Palliative care services aspire to achieve the ambitions, which is a national framework, which you may or may not be aware of. And actually, if you look at these things, I think they really relate to any services. And as a patient, and obviously I'm a patient just as much as all the rest of us, these are all the things I think that we can understand are really, really important. I think in relation to patients with a palliative diagnosis, I think the first point is absolutely paramount. And with that, patients often will talk about, as Alison was alluding to, the importance of having the opportunity to have honest, informed and timely conversations about what matters to me as an individual, and who can support me with what might be possible and what's important to me, but also knowing that actually I might die in the near future, and that near future might be years, but it also might be a shorter time period. I think it's fair to say often for healthcare professionals who don't regularly work with patients with a palliative diagnosis, it can feel very difficult to talk about dying and death with patients. Healthcare professionals often worry about saying the wrong thing, often worry about upsetting people. And research really has shown that patients often will talk about wanting to have conversations about things that concern them at an early point, and not at crisis point. And I have seen patients where conversations haven't taken place, and I think it's human nature that we try and make sense of what's happening to us. And just as an example, there was a lady that I was seeing who had been very unwell and been in hospital and thought she was dying, hadn't discussed it with anybody. She did actually manage to come home, and the symptoms she was experiencing every time she had these symptoms, she thought she was dying. And so she was taking medication, which was making her feel very sleepy. And she had taken to her bed because she thought, you know, any day I'm going to die. And actually, as a team, we went in and supported her and helped her to understand her symptoms that were normal and that weren't indicative of the fact that she was actually in her last days. And we were able to reduce her medication. She was able to return to sleeping upstairs with her partner. She had a much more active life in just being able to talk about and make sense of actually what was happening to her. So those conversations are actually of paramount importance. The other point I wanted to make is that obviously we all hope that care is coordinated, but the number of people involved with patients with a palliative diagnosis can be high in number and can be in different care settings. We work very closely with the oncology team in the hospital. We work very closely with our colleagues within the primary care network, such as the GPs and the nurses and the care coordinators. We work closely with community nurses and other professionals supporting patients in their own home. And I think all of us understand at the moment that with service provision such as it is, we don't always get it right, and care doesn't always feel coordinated, but we certainly need to be aspiring to it. And I think one of the big messages that I often say to patients is, if you're getting into difficulty, phone somebody, because it can sometimes feel very complicated knowing who might be the right person. And at the end of the day, it's just reaching out to somebody. And saying, you know, actually, I need some help, but I don't know who the right person is. And the last point about community being prepared to help, these people often feel very, very isolated. They will often talk about, you know, my friends don't contact me because they don't know what to say to me. And I do think as a nation, culturally, we find it difficult talking about dying, but often these are the times where people with palliative diagnoses really need people around them to feel comfortable about talking about loss, which might not be about loss of life, but just loss of a role, loss of function, and these kinds of things. So, you know, we need to get to a point in sessions like these where we feel more comfortable talking about these things in order to be able to support each other. I'm not going to talk about who provides palliative care because we've talked about it a lot, but essentially it's not just about specialist teams and it's not just about hospice care. As we've talked about, GPs, practice nurses, people coming into your home as carers, you know, therapists, community nurses, all of us are providing palliative care, but with different levels of expertise. So just in Portsmouth, I work for a multi-professional team that visits people in their homes. So at Macmillan Professionals, we have a consultant, we have clinical nurse specialists, there is myself and another physiotherapist, we have occupational therapists, sorry, I've just said consultants again, we have social workers and we have clinical psychologists. We tend to see people who have more complex needs and often see people who are in their last year of their life, but not exclusively. As a service, we recognise that actually there are patients that we've not been able to reach or that other services aren't supporting. And so we basically are developing, we've just had someone start in a post this week for an enhanced supportive care clinic. And the intention of this is to be able to provide earlier therapy and nursing support to patients who often are not being seen by existing health services. They do need to be patients who have a life-limiting illness, and we will be focusing on cancer patients to begin with. But these are often patients who our colleagues, the clinical nurse specialists who work in oncology, are saying the patients who may not be having treatment, they just don't have the capacity to be regularly supporting them. And unless someone is getting into a crisis, often then don't reach out to a healthcare professional. As part of our scoping work, for this project, we spoke to service users and caregivers for their opinion on what this service might need to look like, what we might need to call ourselves as a service. And we were really understanding the barriers to accessing services if something has a hospice label or if something has a label of palliative care, because often people don't perceive that unless they're in their last few weeks of life, that actually that palliative care services are for them. So we have deliberately not put palliative care in the title, And the intention is that we're really supporting people at the point that they've been diagnosed with having a life-limiting illness, and working alongside primary care, working alongside the hospital services and all community services, and supporting patients and being able to have open access into the clinic once someone's actually been able to access us in the first place when they start running into problems. So it's really trying to support people to live well and actually dispel some of the myths in order to be able to access other services that exist. Around us, we have what's called the Living Well Centre, which is run by the Rowan's Hospice, which is our local hospice. And this is a drop-in centre for patients or their families. It provides a huge range of complementary therapies. They do group work, they do one-to-one assessments. There are therapists who work there. There are lots of social activities and emotional support. They provide a brilliant service. But for some patients, they don't want to access it because it has the hospice label, or transport there because it's outside Portsmouth is difficult. But its existence is there for patients. And then we also have an inpatient unit when we've talked about, and there are obviously other places around providing specialist assessment and treatment with complex symptoms, as well as care in dying. So many of our patients may go in there. If we're treating someone in the community and it's difficult to get on top of someone's symptoms, the benefit of being able to be in an environment where 24/7 there's professionals around that can really try and get to grips with symptoms, to try and support them to then get them back home. Where time is limited, that is hugely beneficial, where it might take a lot longer in the community. So as a physiotherapist, how can I help people? So basically, we provide holistic assessment, as I've described, so really trying to understand what the issues are for the individual. We do a lot of sense making of information, compassionate communication, really acknowledging loss. And as I was talking about, a lot of that loss is about a loss of things that someone might have been able to do before, a loss of identity, a loss of role, and sometimes actually really looking at some of the medical information they've been given and trying to understand the implication of that from a physical perspective in particular. We do a lot of promoting self-management for the individual, but also their caregivers, and looking at coping skills and looking at how can I still achieve that, but maybe I need to try and do it in a different way so that I still have really good quality of life. And part of that, I mean, not everybody wants to set goals, but for some people actually saying, I really want to be able to do this by then, or I still really want to be able to sleep upstairs with my partner, I want to be able to walk my children to school, is really important. And our job is about looking at symptoms or situations and trying to understand, is this just because someone's been less active because they've been feeling really rubbish from their treatment? Is this because of their disease pressing on different things and causing problems? Or is it that someone's treatment is causing someone, for example, to be very, very fatigued? So what can we actually improve, or what is going to be something long term that we need to try and see how can we work around this for someone to still have really good quality of life? Providing rehabilitation, really maximising function and improving quality of life regardless of what someone's prognosis is, and really supporting people to be able to engage in meaningful activities that are really significant for them. I'm going to skip over the next slide because I know time is really limited. These are just the sorts of things that we might do, but I just want to show you a video clip, and I've put two on. I'm not going to show you both, but I'm wanting to see if I can click on this video clip, and hopefully you'll get the voice, because I think there's nothing better than a service user's voice of what actually a difference this sort of intervention can make.
Yeah. Claire, if they don't work, we will share these videos. So we'll see if it works.
Can you hear that?
Yep.
Excuse the
I'm
music.
Paul Fitzpatrick, and I'm 61 years old. And at the end of January 2018, I was diagnosed with 2 life-changing conditions. The lung disease that I have is called IPF, which is idiopathic pulmonary fibrosis. And what it is, it's the hardening of the lungs. Your lungs are like a honeycomb, and it blocks up the honeycomb and it stops your breathing properly. There's no actual cure for it. The only cure for it is a lung transplant. But I'm not eligible for a lung transplant because I also have a cancer, and they can't operate on the lungs with the cancer, and they can't operate on the cancer with the condition of the lungs. So I'm caught between a rock and a hard place. Before I got my illness, I was working full time as a truck driver, and I was enjoying life to the full. Have a few grandchildren which I enjoy being with. I'd go out down to the park with them, and I was fairly active. But when I got these diseases, everything just changed. The consultants recommended me that I should go to St. Francis Hospice for palliative care. And when I heard this, it scared the life out of me. I didn't know what to do or think, but I'm glad I took the step.
We're never going to be able to fix patients' lung disease, and you know, the patients are aware of that when they come into it. But what we aim to do is improve their cardiovascular fitness and strengthen up their leg muscles and their arm muscles to make them a bit more efficient as well. So we have a program here called Exhale, which is an exercise and education program set up here in St. Francis Hospice for people with advanced lung disease.
I then went down to the hospice, and the first day I arrived, it wasn't like what I thought it was going to be. The staff were so caring, and they explained everything what they wanted to do and how they wanted to help me manage and treat my pain. So I started doing complementary therapy first, and this helped me relax and helped my breathing and gave me more confidence.
So the people that will come onto this program will probably have tried the more standard pulmonary rehab programs in the community before, but might have found it just a wee bit too difficult or too challenging. So a really unique part of our program, I believe, is that we pitch our exercises in each individual's level.
And after the first couple of sessions, I could feel my breathing getting better, and I could start to do the simple things in life, like going up the stairs or going to the shops, which I found very hard to manage before. From being down in the hospice and the treatment that I've got down there, and the love and care and kindness has helped me progress through this. And from this time last year, I'm out and about, which I thought I'd never be able to do again.
I'm just going to pause it there, just because I know time's really limited, but I just think often we think actually things aren't possible to change, but actually with the right sort of support, often we can really physically help people improve and actually be able to do things that are really important. So thanks ever so much for listening, and I hope I haven't talked too long.
Fine, Olivia, thank you. And you know, I think it's just an example of how much this conversation is needed. Absolutely, because usually these sessions stick strictly to time, and sometimes we finish way before we're supposed to. And I think that just is a sort of example of how much we need to be talking about this. So thank you. We are recorded, so we're going to share. So I'm going to swiftly, so thank you, Olivia. I'm going to swiftly move on to Paul. Thank you for being so patient, Paul.
And am I still sharing my screen? Because I can't seem to stop sharing. Yes. Let me see. I'll be in the background, but I'll try and stop sharing it. I do apologise.
Perhaps when Paul tries to share his screen, if he's
oh, there we go.
There. Paul, hello. Thank you for being so patient.
That's fine.
Valuable, like I say. So great.
It's been an amazing session. It really has. So Jackie, hopefully you'll be able to put the presentation up. I feel after everybody else today, it's going to be quite lame, but here we go. So I'm Paul. I'm the registered manager and the lead nurse for the Living Well service at St Michael's Hospice in Basingstoke. I've been in palliative care for about 9-10 years now, all at St Michael's. I can't imagine working anywhere else. And various roles. I'm a nurse by trade, worked on the inpatient unit, hospice at home, our community palliative care nurses, and now I've just got the role of setting up what we call our Living Well service. So it's a kind of combination of the two, and apologies for my colleague Chris Bagan, she couldn't actually make today, but I just sort of talk a little bit about the myths of palliative care and how hopefully the Living Well service will fit in with things. So if we could have the next slide, Jackie, please. So it is a big thing. I think we all appreciate that, and there seems to be that current theme throughout today about the various myths surrounded. So we've actually got this on our website, a little tab about the myth busting. And I know we've talked about some of this already. You know, hospice is where you go to die. All hospice patients are elderly. Nursing in a hospice is just about providing comfort. So again, people think it's for just purely end of life. Hospice is for people with cancer. You know, there's a lot of life-limiting illness and disease out there: heart failure, COPD, neurological diseases such as motor neurone, Parkinson's, which we really want to engage with as well. And we're very fortunate at St Michael's. We run a monthly motor neurone disease clinic, so we've got a lot of MND patients on our books. And people in hospices are always sad, and these actually came from our patients and their families when we asked them before they'd sort of their views before they encountered us. So if we could have the next one, Jackie, please. So what our Living Well service is intended to do, say we just started up, is basically to be a safe place for people to come, and just that maybe initial dipping the toe in the water of what a hospice is and what you sort of get out of hospice. We've called it the Living Well service, which is quite positive wording. And basically we want people to find the group support from us, from each other, and recognizing our own limitations. You know, we're a small 10-bedded inpatient unit hospice. Although I've got the role of setting up the Living Well service, there's not the budget to being an independent hospice to provide me with staff. So it is basically me stealing staff from the various departments in St Michael's. So a lot of signposting, a lot of working together with our colleagues like CSP, which is really, really important. And as I say, hopefully it will be the first step for some of our patients and their loved ones into what a hospice is and what hospice care entails. If we could have the next slide, Jackie, please. So the key points in setting this up is basically what do our patients want and need. It's all very well. I think we can often have a vision of exactly what our patients want and need, but again, the recurrent theme from today is everyone's an individual, and actually what we think people might need, they don't. So we've used what we call some hugs, our hospice user groups, to ask what people actually want from the Living Well service, what we can offer, and as I said, recognizing our own limitations, really. Next slide, Jackie, please. So I've got a couple of scenarios to move on to. The things that we are currently providing, which have gone down very well, seated Pilates. The feedback we've got from that has been amazing, and also every little thing we do, every little sort of introduction to various programs, it's helping people realize that, wow, a hospice has got a physiotherapist, or the hospice has got occupational therapists, complementary therapists, they've got a chaplain. So it's all these little things where we can, you know, holistically, you know, let people know what's on offer. So for our creative workshop, which we just set up, being a mere male, creativity isn't a strong point, but fortunately we've got a strong bank of volunteers and one is very much into arts and crafts, and suggested, because the pilot was in the run up to Christmas, why didn't we make some Christmas wreaths? So that's what we went with. We had 6 patients turn up, and it went down really well. But the main thing is, as I say, is getting the people to just come to the hospice for that. And we're quite fortunate because the building we're housed in is attached, but you don't physically have to go into the main hospice. So one lady that was referred in by her community Macmillan nurse was a 44-year-old female with stage 4 bowel cancer. She'd never had any contact with St Michael's, just with her community palliative care nurse. And she phoned a couple of times. The first 2 occasions, said, "I'm really sorry, I'm not feeling up to it, I can't make it." But then she did come, and she was incredibly anxious, 1 about coming to the hospice, 2 about kind of, you know, seeing other people. So we made the introductions, said what we'd be making, and after 10 minutes, this lady turned around and said, "I don't know why on earth I didn't come sooner. I've not felt this relaxed for ages," which just melts me. It really does. And the next thing she said, and I was just so proud of her, if we sort of start talking about addressing elephants in the rooms, she turned to the lady next to her and said, "Can I ask what your illness is?" And that must have taken a lot of strength, knowing, you know, she was pretty poorly herself. So she told her, and then, you know, the return question. And the whole idea of this is that people actually talk about everything and anything, and get support from each other. So once they'd talked about that, we moved on to what would it like to be going on to a cruise, what the best soup maker is to buy, you know, so that the conversations are really random, but that's what it should be about, you know. And the wreath making was going beautifully, but I'd say to everyone there, it's not your productivity, it's just that, you know, mutual support, that having those conversations. And they get on like a house on fire, these 2 ladies now, to the extent that, again, the lady in question is still a bit nervous about trying other things, and this other lady is a huge fan of complementary therapy, which we offer, and she mentioned it. "Oh, I'm not too sure." She says, "Well, give it a go, you've got nothing to lose." So appointment was booked for with one of our complementary therapists, and this lady had originally asked for a hand massage because I think she just wanted to kind of play safe, and our complementary therapist said, "That's absolutely fine, I will do that for you. However, it can be a bit up close and personal. Have you thought of reflexology?" Which, you know, I'll be down by the feet, so I'm the far end of you. I said, "Oh, okay, let's try that." So I saw her leaving and said, how did it go?" "Oh my goodness, I've booked my next appointment already. I was so relaxed." She said, "I think I fell asleep for a time." And then when she came back to the workshop the following week, she said, "Paul, that was amazing, that complementary therapy. You know, I went home, fell asleep in the afternoon again. I can't remember the last time I was that relaxed." So yeah, I was really pleased, and that's kind of the whole narrative really of what we want from these things. So that's one example. Jackie, could we have the next one, please? There it is in its full glory. And again, working on a shoestring, it's just a polystyrene ring with strips of Christmas ribbon, cut and folded and pinned onto a thing, but people absolutely loved it. So next slide, please, Jackie. And then the second scenario, so have got some funding actually to make one of the larger rooms, it was the reception, into a proper cafe. So I know Eileen and Jackie have seen my attempts recently. Basically everything I've got in there I've stolen from the main hospice. I have bought a tablecloth for the big table, but this week we actually get an all singing, all dancing coffee machine. We're going to have new furniture, lots of different height tables to allow wheelchair access. Hopefully we'll be able to sell a bowl of soup or whatever, so there'll be food there, cakes, and just making it a welcoming space. But at the moment I'm kind of restricted to just a large table with seats and a flask of hot water that I kind of run around and make coffees with. But one gentleman came in, and before I'd done this, he'd bring his wife in for complementary therapy, and he would sit in the corridor on a chair doing a word search. So once I got my tables and chairs in, I said, why don't you sit in there? So he sat there, and I said, look, let me get you a coffee. You know, do you fancy a chat? And he just opened up, which is quite rare for us men. It's not our forte. And he just started talking. And he'd recently retired to support his wife at home. He had a job which was in, outside, and a very sociable chap. So that had suddenly gone from his life. And then we started talking about his wife as well, that her motor neurone disease is quite progressive. And virtually every week there's something else. There's a loss of or deterioration in her functional ability. And he was really having trouble kind of getting hold of this and dealing with it. So we just started talking about grief and loss, and actually seeing his wife lose this certain abilities. Last week she could unscrew a jam jar. This week she can't, and it won't come back. And when I put it into the context that this is grief, this is recognizing loss, and it will happen, it really made sense to him. And now I make sure I'm there every time he brings his wife. So my next thing is to actually get some carer support groups running, where we can just talk about anything, and then again signpost the carers as much as our patients, because again, what's already been mentioned today, they're feeling it as well. They're having their own issues. And I think sometimes families and carers can get overlooked, because we concentrate on the patient and kind of forget what the loved one is going through as well. So that's my little spiel, really. And I'll, again, with the signposting, I don't know if Alex is still on, but I'll certainly be getting on for things like the 5K Your Way, getting in contact with him, because anything we can do to make our patients and their loved ones live well is worth doing.
Thank you so much, Paul. And Jackie and I can very much vouch. We have visited and we've had coffee, and we attended one of those sessions. So where there were service users there, wasn't there, when we were there, and it was lovely just to sit and have a conversation. I mean, it's totally and utterly invaluable, and we need to shout out about these services more and be open and have conversations like this. So that's great, and thank you very much, Paul, for your time, because I know you're on leave this week, aren't you?
Yeah. Thank you.
Happy annual leave. Thank you. So we have run out of time, and Fran, I can see you're still here. Would you like to go through
Entirely up to you. I've got it down to 6 bullet points, which I can say very quickly in case anybody wants to go back and have a look at the recording. Does that sound sensible?
And is that okay with everybody? Jackie and I are fine with that.
If you want to say goodbye to everybody first.
Yeah, so if anybody needs to go, I mean, obviously just thank you for sticking with us, but as always, you know, it just shows how important it is to have these conversations, so thank you. Over to you, Fran. Thank you.
Over to me. Yeah, and I have to say, every time I come here, I think we are so lucky to be in this patch, to have you, which not all the hospitals are supported by such a great group. We've got Macmillan, and we've got some just brilliant services that are up and running out there. But we also know that the NHS is under incredible pressure at the moment across all sectors, be that primary, secondary, or community care. And we need to get better at being able to support people at universal level, so that not everybody comes in to needing that clinical support. So the service I just wanted to mention briefly builds on WesFit, which was very much a prehabilitation service, SafeFit, which took the elements of WesFit into being much more universal, so that it could support anybody with a cancer diagnosis at any point in their diagnosis. Those trials have now both come to an end. WesFit certainly showed a bed reduction of 2 days in terms of length of stay, so you can tell by that what impact it had. And we're now working on Fit for You, where we're taking the elements of SafeFit, which is that nutritional support, that emotional support, and also exercise, physical activity support, but focused at patients with metastatic or locally advanced disease. Initially looking to pilot within HHFT, with the caveat that this has been supported at the Cancer Services Board, but we still are awaiting sign-off by the Director of Finance. Hopefully that will happen, and when it does, I will pull together a meeting for all key stakeholders across the patch. But just to say, in terms of Fit for You, cancer support workers, be they sitting in primary or secondary care, are absolutely going to be integral to getting this one right. We're working with and upskilling a workforce in the community, that is the fitness instructors who are trained up to level 4 cancer support. So this is another workforce that's there, but we are not currently utilising to the full extent that we should be able to. It's all about joining up the dots. There are some amazing services out there. Olivia talked about that Claire has, that Paul has just there. We don't want to replicate. We don't want to be a parallel universe. It is all about dovetailing with those services and joining the dots. It is all about giving the patient back control. So just thinking back to Sue's brilliant presentation about what matters to me and my goals. And as I said, as soon as we have got the Director of Finance to sign on the dotted line, I will pull together a meeting, initially with the key stakeholders in the HHFT area, but this is something that we want to look at system-wide to go across the whole of the Hampshire and Isle of Wight ICS.
Brilliant.
Thank you.
No, thank you for being so patient, Fran, and fingers crossed.
Fascinating, that wasn't patient.
Yeah. It's just hopefully, fingers crossed, that gets signed off by the end of this month, but we will see.
If not, we'll need to be getting some pressure groups going,
yeah.
and
Absolutely,
etc. So thank you again. I really enjoyed this morning. It's gone so quickly.
It has, hasn't it? And we're always conscious of time. So really, what else can I say? Just thank you so much. And I just think it really identifies how key these conversations are. And we must keep having them. We need to really think about what we can do for our next bi-monthly. So have a think about that. For those of you that are left, we will be asking that question when we email out all these notes and the slides, etc. So thank you very much. Take care of yourselves. Until next time.
Thank you.
Bye.
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 Many thanks, Eileen. Bye.
Bye. Thank you. Thank you.